Good afternoon, everyone. Welcome to the National Hispanic Council on Aging's virtual Capitol Hill briefing. My name is Oscar Ramirez. I'm the co-founder of Fulcrum Public Affairs. It's my pleasure to moderate today's virtual event and to be part of the release of the executive summary of the 2023 status of Hispanic older adults addressing health disparities. Every year during Hispanic Heritage Month, NHCOA takes a pulse of the Hispanic older adult population and presents an annual status of Hispanic older adults, a data and testimonial-driven status report with policy recommendations that capture pertinent hardships and challenges that Hispanic older adults face. In 2023, NHCOA decided to focus on addressing key health disparities impacting Hispanics, including osteoporosis, Alzheimer's, obesity, and COVID-19, among others. NHCOA is grateful to those that have contributed to the status of Hispanic older adults addressing health disparities edition. This report was produced with the support of several organizations and individuals, all of whom are committed to the well-being of Hispanic older adults, their families, and caregivers. Their assistance was invaluable in collecting data from the Osteoporosis National Survey, formulating recommendations, and preparing the report. We would like to recognize NHCOA staff members who contributed their time and effort to the development of this report. For those who would like to read the report, it will be available on NHCOA's website and social media platforms after this virtual briefing. We also welcome a panel of experts who join us today to provide context to the executive summary of the report. This virtual advocacy day would not be possible without the generous support of our many sponsors. So thank you to Lilly, Verizon, Pharma, Pfizer, Better Medicare Alliance, ASI, Elevance Health, and Novo Nordisk. To begin the virtual event, it is my pleasure to introduce Dr. Yanira Cruz, President and CEO of NHCOA, and one of the nation's foremost advocates and spokespersons for diverse older adults. She has been recognized for commitment and leadership on behalf of diverse older adults nationwide. Welcome, Dr. Cruz.
Thank you, Oscar. Thank you for that kind introduction. And hello, everyone, and welcome to NHCOA's Capitol Hill briefing. Thank you all for joining us today at this pivotal event that each year brings together a broad group of outstanding representatives within the community to promote ideas and solutions to address pressing issues of the Hispanic community. I want to extend, first of all, my deepest appreciation to the esteemed congressional members present here for their tireless dedication to serving our community. Your unwavering commitment to addressing the concern of our community is truly commendable. I also want to express my gratitude to our distinguished panelists for taking time off their busy schedule and joining us today to help us shed light on critical issues that resonate deeply within our community. Your insights and expertise are invaluable in our mission to effect meaningful change. In addition, I'd like to extend heartfelt thanks to our generous sponsors, to Lilly, Pharma, Pfizer, Verizon, Better Medicare Alliance, Elevance Health, and Novo Nordisk. Their support fuels our mission of improving the lives of Hispanic older adults and their communities and amplifies our reach. I want you to know that your partnership empowers us to make a lasting impact. So thank you. Today, I want to start by emphasizing the significance of our osteoporosis research. As you may know, every year, NHCOA releases its annual Status of Hispanic Older Adults report. The report provides a comprehensive overview of the needs, the challenges, and resilience of our Hispanic older adults, including a literature review and analysis of feedback and input from local communities around the country, gathered in a series of surveys and focus groups. This year, NHCOA took the pulse of the Hispanic community about their knowledge, attitudes, and beliefs and behaviors around osteoporosis. Even though we are diving into the details later in the event, I want to just highlight a finding that is particularly important. Osteoporosis is viewed by Latinos as a condition that is not impacting them. But this perception couldn't be farther from the truth. Osteoporosis indeed is a serious health concern, and we must strive to raise awareness within the Latino community. Knowledge is power, and it is the imperative that our community becomes informed and takes proactive steps to address this condition as soon as possible. The findings and analysis of our assessment underscores the urgent need to create a robust informational campaign aimed at educating Latinos about osteoporosis. PBMs were originally designed to reduce out-of-pocket costs for patients. Unfortunately, it has deviated from its intended purpose. As for today, just 3 PBM corporations control almost 80% of the prescription drug marketplace. This control of the market gives PBMs enormous power in negotiations with pharmaceutical companies. They can exclude drugs from the list of medications covered by insurance, called formularies, if those medications aren't sufficiently lucrative for the PBM. We stand here today to advocate for key legislation in Congress to rectify this situation. The PBM legislation is of utmost importance. We call upon Congress to ensure that the program serves its original purpose, benefiting those it was meant to help. Another critical piece of legislation we urge for is related to Alzheimer's. According to the Alzheimer's Association, about 13% of Hispanics who are 65 or older have Alzheimer's or another dementia. Building efforts for finding a cure and making medications accessible to affected individuals should be a pressing matter for all of us. Waiting for years for these medications is an injustice that our community should not endure. Finally, I also want to point out that we cannot ignore the profound impact of COVID-19 on the Latino community. Even now, we continue to deal with the repercussions of this devastating virus. The higher rates of COVID-19 related death among Latinos are a painful reality. And it is imperative that we advocate for equitable access to healthcare and make COVID-19 treatments available to all, regardless of their circumstances. We at NHCOA continue our effort to educate our community about the virus and make sure everyone has fair access to the vaccines and booster shots, as well as treatment. And we invite everyone to join our mission and help stop the spread of the virus. I want to extend my gratitude once again, especially to all of you, the audience, who are joining us today for our event. Your presence here, along with your unwavering support of NHCOA's mission, is the driving force behind our work. Also, special thanks are due to our dedicated moderator for today, Oscar Ramirez, who continues to support our work, and we appreciate that. Together, let us continue to work tirelessly to address health inequities impacting diverse adults, striving for a brighter and healthier future for all. Thank you, everyone. Turn it over to Oscar.
Thank you, Dr. Cruz. And now let's continue with our next speaker, Mr. Jorge Lambrinos, Chairman of NHCOA's Board of Directors. Mr. Lambrinos has acquired considerable experience in government and politics and in policy as Chief of Staff to former Congressman Edward R. Roybal. Mr. Lambrinos helped the Congressman establish the Edward R. Roybal Institute of Gerontology at Cal State LA to provide gerontology training to students interested in pursuing a career in aging. He served as the first director of the Gerontology Institute. The institute was subsequently moved to the University of Southern California, and he became the director there. He also is presently a lecturer on aging policy and leadership at various colleges and universities in the area. Welcome, Mr. Lambrinos.
Good afternoon, everyone, and welcome to the National Hispanic Council on Aging's 2023 virtual Capitol Hill briefing. I am Jorge Lambrinos, Chairman of the National Hispanic Council on Aging's Board of Directors, and it is my pleasure to be here today. The purpose of today's briefing is to give the National Hispanic Council on Aging the opportunity to give you an update on important health issues impacting the nation and how these issues affect Hispanic seniors. Before we get started, though, I want to thank Senator Chris Van Hollen from Maryland and Congressman Raul Ruiz from California for sponsoring the Capitol Hill briefing. Today, we are going to highlight the impact health inequities continue to have on our population. While we have made important progress in the nation in terms of access to health care, Latinos continue to lag in many areas. Unfortunately, COVID hit us hard, and Latinos experienced the highest rate of death related to COVID. It is important that the treatments available to treat key conditions, including COVID, are available and accessible to everyone, including Hispanics. For instance, I want to highlight two specific pieces of legislation that Congress needs to consider and pass for the benefit of older adults and the general health of the country. First, the Treat and Reduce Obesity Act, also known as TROA, is an important piece of legislation that Congress should be paying attention to and hopefully will pass. Obesity is hitting our community hard, and we are calling on Congress to act and pass legislation that will give those who are benefiting from Medicare access to the full spectrum of anti-obesity medications and treatments. Another is the Pharmacy Benefit Managers legislation, also known as PBMs, that needs to be voted on and passed on so that systematic errors that are impacting access to healthcare can be fixed. PBMs are companies that manage prescription drug benefits on behalf of health insurance, Medicare Part D drug plans, large employers, and other payers. By negotiating with drug manufacturers and pharmacies to control drug spending, PBMs have a significant behind-the-scenes impact in determining total drug costs for insurance, shaping patients' access to medications, and determining how much pharmacists are paid. The Senate Finance Committee recently reported out the Modernizing and Ensuring PBM Accountability Act, also known as MEPA, that would address PBM concerns regarding transparency, delinking PBM income from drug prices, and contract fairness. This bill will likely be voted upon by the full Senate this fall. Finally, we need to consider the NAPA Reauthorization Act, a bill to extend the National Alzheimer's Project. This landmark legislation was signed into law in 2011. The NAPA Reauthorization Act emphasizes the importance of healthy aging and risk reduction for Alzheimer's disease to reflect the new sixth goal of the national plan. In addition, with the original provisions of the Alzheimer's Accountability Act, which was enacted in 2014 and is set to expire in 2025, Congress must renew its commitment to ensure that progress continues to be made in Alzheimer's and dementia research. The Bipartisan Alzheimer's Accountability and Investment Act, Senate 134 and House 620, would continue to prioritize Alzheimer's and dementia research funding at the NIH. Despite the United States' status as a developed country, we continue to lag behind many other nations in terms of access to healthcare. Today, you are going to hear from experts who will expand the importance of these topics and present the results of a national survey on osteoporosis and Hispanics. We hope that this briefing is educational and will shed light on key health disparities impacting Hispanic and Latino communities. Thank you and enjoy the sessions.
Thank you, Mr. Lambrinos. And before starting with the panel session, let's welcome Ms. Yarisa Reyes, who is a National Director of Diversity, Equity, and Inclusion Engagement at the Alzheimer's Association. In this role, Ms. Reyes works with the association and external leaders to assess, identify, and execute on new and ongoing partnerships with organizations that advocate for the well-being of underserved and underrepresented communities. She leads the Hispanic Latino outreach on behalf of the association, and under her leadership of the association has broadened its reach to previously underserved communities. Welcome, Ms. Reyes.
Thank you, muchas gracias. And hello, everyone. Happy to be here today. At the Alzheimer's Association, we believe that diverse perspectives are critical to achieving health equity, meaning that all communities have a fair and just opportunity for early diagnosis and access to risk reduction and quality care. The Alzheimer's Association is committed to engaging underrepresented and underserved communities and responding with resources and education to address the disproportionate impact that Alzheimer's and dementia has on these communities. We know that due to the overlapping systemic and cultural barriers that make access to diagnosis more challenging, early signs of cognitive change typically go unnoticed or undiscussed in Hispanic families. And too often, a diagnosis happens only in a moment of crisis and/or an emergency. The Hispanic community remains disproportionately at risk for dementia at a rate of 1.5 times more likely than non-Hispanic whites to develop the disease. We know that Hispanic Latinos are often diagnosed later in the course of the disease, when individuals are more cognitively and physically impaired and therefore are in need of more medical care. Alzheimer's is a type of dementia that causes problems with memory, with thinking, behavior. Symptoms usually develop slowly and get worse over time, becoming severe enough to interfere with daily tasks. And we know that more than 6 million Americans are living with Alzheimer's, and that 1 in 3 seniors die from Alzheimer's or another type of dementia. And while there is no cure for Alzheimer's currently, there are new treatments that can slow down the progression of the disease. But these treatments are only available to individuals in the earliest stages of the disease, making early detection and diagnosis critically important. We know that close family members who know their loved ones best are typically the first to notice memory issues or cognitive problems, but they're often hesitant to say something, even when they know something is wrong. So the Alzheimer's Association, a month ago, developed and launched a new public service advertisement called Some Things Come with Age. This campaign is aimed at increasing early detection of Alzheimer's and other dementias within the Hispanic community by raising awareness of the early signs and symptoms. The purpose of the Alzheimer's Awareness Campaign is to empower family members to have a conversation about Alzheimer's if they notice a difference in their loved one's attitude or behavior. The campaign highlights the benefits of early detection that includes access to treatment options, access to emotional and social support groups, more time to plan for the future, and patient involvement in creating a care plan. There's a lot of exciting progress in Alzheimer's and dementia in the research that is conducted, but we know that a lot of people don't really know a lot about the disease. So it's important for families to learn as much as possible about which drugs are available and how to talk about treatment options with their loved ones and with their doctors. So we encourage everyone to check out the new campaign on alz.org and learn more about having these conversations with their loved ones. Experts believe that the key to addressing the issue is continuing research around Hispanic Americans and dementia, as well as increasing the number of Hispanic people participating in clinical studies. The Alzheimer's Association continues to support research that advances understanding of racial and ethnic differences as it relates to Alzheimer's. And as mentioned before, there are a couple of key legislation that we are supporting that would help specifically with this regard. The NAPA Reauthorization Act, the Alzheimer's Accountability and Investment Act, the Bold Infrastructure for Alzheimer's Act, and of course, the Congressional Task Force on Alzheimer's Disease. I thank you for your time today, and please know that if anyone is affected by Alzheimer's or another type of dementia, the Alzheimer's Association is readily available 24/7 through our helpline, 800-272-3900, or through our website, alz.org. Thank you for your time, and thank you for having me.
Thank you, Ms. Reyes, for talking about that very important issue. Now let's start with our panel session. According to the Alzheimer's Association, Hispanics are about 1.5 times as likely as whites to have Alzheimer's, a brain disease that slowly destroys memory and thinking skills and eventually interferes with the ability to perform everyday tasks. For our older adult population, we all know that age is the greatest risk for Alzheimer's, and our population is aging rapidly. Let's hear more from our first panelist. Our first speaker is Dr. Michael Irazade, Senior Vice President of Clinical Research and Deputy Chief Clinical Officer of Alzheimer's Disease and Brain Health at ASI. He is responsible for the overall strategy and clinical development of the company's neurosciences portfolio, including clinical pharmacology and translational medicine. Dr. Irazade will speak about the status of Alzheimer's among Hispanics.
Great, thank you so much. It's a pleasure to be here. Today, I'll reinforce what we've heard already about the impact of Alzheimer's disease on the Hispanic community. And I'll also discuss the importance of ensuring that the Hispanic community is appropriately represented in Alzheimer's disease clinical trials to ensure that we can understand how treatments work in Hispanics, as well as a range of people that may be eligible for treatment. Next slide, please. So Alzheimer's disease is a progressive brain disease where nerve cells die, and the earliest symptoms is a decline in memory, and in particular, a decline in the ability to learn new things. Then over time, people may have difficulty with language or daily activities, maybe starting with difficulties balancing a checkbook or difficulty driving. As the disease progresses, people become more dependent on assistance from their family or other caregivers. Also, as the disease progresses, people may experience changes in personality and behavior, including depression, agitation, and anxiety. And each person progresses differently through the course of disease, which can last for 5 to 10 years. One thing that I wanted to highlight is that dementia is the term that's used for the symptoms of cognitive decline and functional decline. And Alzheimer's disease is one of the main causes of dementia. But for people that have a decline in memory or function should be evaluated because there are other potential causes of dementia, such as multiple strokes, or potentially the effects of medications or other things that could be treated. Alzheimer's disease is the most common cause of dementia, and it's characterized by elevated amyloid in the brain. So there's a protein in the brain that's elevated, and now there are tests, imaging tests or spinal fluid tests, and soon blood tests in the future that can confirm that amyloid is elevated in the brain and can confirm a diagnosis of Alzheimer's disease. Next slide, please. Alzheimer's disease has a significant impact in the Hispanic community, especially as that community ages. As you've heard, aging is a major risk factor for dementia and Alzheimer's disease. So on the graph here shows the rates of dementia by age in different race and ethnic groups. So for instance, in white, for people between the ages of 65 to 74, the proportion of people with dementia can range from 2.8 to 6%. That almost triples by the age of 75 to 84 to between 12% and 19%, and then even doubles again by the age of 85 or older. And in particular, the rate in Hispanics appears to be higher than those in non-Hispanics as well. In addition, Hispanics may experience a delay in diagnosis, poorer quality treatment, and lower access to evidence-based or non-pharmacologic interventions. Next slide, please. So in addition to the impact of Alzheimer's disease on the Hispanic community, the increased rate of dementia relative to non-Latinos, the increase over time that's expected with the aging population, there may be differences in how dementia manifests in Hispanics and Latinos. There may be more likely to have neuropsychiatric symptoms such as depression and anxiety. And about a third in surveys may report experiencing discrimination when seeking healthcare for cognitive decline or dementia. And all surveys also indicate an underutilization of long-term services and supports. The other idea that I'd like to discuss is the importance of representation of Hispanics in clinical trials for Alzheimer's disease, in order that we can develop drugs and treatments that can improve the life of people with Alzheimer's in general, and in particular understand within diverse groups as well. And in prior clinical trials over the past 10 years, there's been a very low proportion of Latino Americans represented. And the table here lists that proportion within those clinical trials. And our company, AZI, has worked very hard to increase the representation of Blacks and Hispanics into our clinical trials. So that last clinical trial of this drug called lecanemab, which was tested in almost 1,800 people globally in early stages of Alzheimer's disease, there were 12.4% of Latinos within the clinical trial. And if you look within the US population, 22.5% of the participants were Hispanic. Next slide, please. So we achieved that first by trying to understand the perspectives of people who would or would not participate in clinical trials. And there's several reasons people choose not to participate in clinical trials. They don't want to be involved in an experiment or be considered a guinea pig. They may be concerned about side effects of an unproven treatment. There's also a burden of participating in clinical trials. There's time and cost involved, and especially for Alzheimer's clinical trials, a family member often has to accompany the patient to the visits, both for also to capture the outcomes of the treatment. So there can be a burden of participating in clinical trials. And in particular, Latinos were more concerned than white Americans about disruption of work and family responsibilities and the availability of transportation and childcare to participate in clinical trials. And prior clinical trials may have also had exclusion criteria. For instance, the types of additional medical issues that Hispanics may have, and whether that would limit their participation in a clinical trial. So ASI undertook an initiative to really prioritize recruitment of underrepresented populations into our clinical trials. And the next slide highlights some of the initiatives that we implemented within the clinical trial of lecanemab that I mentioned. This included selecting investigators and clinical trial sites that had access to diverse communities, and who are also engaged in community activities such as community centers and faith-based groups. Having Spanish language clinical trial staff and clinical trial assessments were critical for including that population in clinical trials. We also tried to reduce the burden of participating in clinical trials by performing more of those activities in the patient's home rather than having to go to the clinical trial site. So this included, for this clinical trial, which was an IV treatment, being able to administer the treatment intravenously at home through a visiting nurse, and to be able to do cognitive assessments or safety assessments remotely. And the other activities included community-based screening and partnership with advocacy organizations. And what this allowed us to do was understand the efficacy and safety of the drug, both overall and within specific populations. So I won't go through in detail what this chart showed, but the overall efficacy of the drug is characterized by the difference relative to placebo in this outcome measure, CDR-SB. And on the top is the overall study results, which shows the estimate of the effect in the dot, and then the range of the effect in the lines next to it. And the dots line up between the white subgroup, the Hispanic or Latino subgroup, and even the Black subgroup. And this is important to be able to generalize the results of a clinical trial more broadly to the general community. This also allowed us to understand the side effects. And this drug, for instance, has side effects of infusion reactions or transient areas of swelling or small areas of bleeding, so important side effects. And this helped us understand that the rate of side effects was not different in these different populations. Next slide, please. So in conclusion, we expect the number of people with Alzheimer's disease to increase with the increasing age of the population, but we've seen significant advances in Alzheimer's disease diagnosis and drug development. We understand the disease better in terms of the risk factors and the progression. We understand better how to make clinical trials more accessible to people. And biomarkers or blood tests or imaging tests or spinal fluid tests have helped us ensure that people actually have a diagnosis of Alzheimer's disease. And increasing diversity in clinical trials is a priority in order to be able to generalize the results of clinical trials to a real world population based on race or ethnicity or the types of medical problems people may have or the other medications people may be taking. It's also important in order to promote fair access to investigational and new therapies that are under development. And also importantly, to help continue to build trust into medical research, institutions, and therapies. So thank you. It's been a pleasure to be able to speak to you today.
Thank you so much, Dr. Irizarry. The moderator had to take a quick call, but in the meantime, I'll be introducing the next topic. So pharmacy benefit managers, or also known as PBMs, have long evaded justified scrutiny for their role in inflating the cost of prescription drugs for patients. Initially created as middlemen to negotiate costs between health plans and insurers, and also to confirm a patient's eligibility and administer plan benefits. PBMs now operate virtually unchecked and gain the system for their own economic benefit. But let's hear more about this topic and its impact on Latinos by our next speaker, who is Steve Postal. Mr. Postal has a DD and is the Director of Policy and Regulatory Affairs at the National Community Pharmacists Association, or also known as NCPA. His areas of expertise include Medicare Part D, compounding, and also PBMs. So today, Mr. Postal will be providing an overview about pharmacy benefit managers, or also known as PBMs, and Hispanic seniors. So welcome, Mr. Postal.
Thank you very much, Christine, and good afternoon, everyone, and welcome to my presentation on PBMs and Hispanic seniors. Next slide, please. Next slide. And the slide after that. So yes, as discussed, my name is Steve Postal, and I'm the Director of Policy and Policy and Regulatory Affairs at NCPA. Next slide. So NCPA represents America's community pharmacists, including 19,400 independent community pharmacies. Together, our members represent a $78.5 billion healthcare marketplace and employ about 240,000 individuals. Together, we provide an expanding set of healthcare services to millions of patients every day. Next slide. So the first thing you might be wondering is, what exactly is a PBM? Next slide. Decades ago, insurance companies expanded their coverage to include prescription drugs. Insurance companies turned to PBMs to process prescription drug claims. So PBMs at a small fee manage claims for managed care organizations, employers, and also government programs. Next slide. Today, PBMs contract with pharmaceutical manufacturers to obtain favorable formulary placement. Next slide. Employers and insurers such as Medicare sign 1 to 3 year contracts with PBMs to manage the prescription drug plans provided to their members and employees. PBMs determine what pharmacies will be included in a prescription drug plans network and how much those pharmacies will be paid for their services. And the PBMs are increasingly affecting Hispanics in Medicare Part D, as Hispanics are becoming a larger segment of the Medicare population. Next slide. PBM pharmacy networks are comprised of various types of pharmacies, and those include independent pharmacies, regional chains, national chains, and grocery stores. Some PBMs incentivize plan sponsors to require plan beneficiaries to use certain mail order specialty or retail pharmacies. And key to note here is that these are often ones that are owned and operated by the PBM. Next slide. So healthcare generally has encountered a wave of consolidation and anti-competitiveness, and PBMs have some responsibility with that trend. The anti-competitiveness has been exacerbated by what is known as vertical integration of PBMs. So for example, you have CVS, which is a pharmacy, but also a PBM, acquiring Aetna, which is a large insurer. You also have Cigna, which is a large insurer, buying Express Scripts, which is a large PBM. So at this point, as discussed earlier, CVS Health's Caremark, Cigna's Evernorth and Express Scripts, and United Health's OptumRx, those three PBMs account for almost 80% of prescription claims. The ultimate purpose of these practices is for PBMs to drive patients and revenue to their own pharmacies. And often a byproduct of this consolidation is that PBMs are running community pharmacy out of the market as they are steering their patients to their preferred pharmacies. Next slide. So this is a pretty wonky slide, but it gives you a good visual representation about what I'm referring to when I talk about vertical integration. But in sum, you have large insurers, which are the first row, contracting with very large PBMs, the second row, who in turn are contracting with their own pharmacies, be they specialty, preferred retail, or mail order pharmacies. And also in these systems, you have even providers that are part of this growing consolidation. Next slide. And PBM practices affect patient care, and often not in a positive way. Key to note here is that PBMs can determine which drug a patient will get, how much patients pay for a drug, the types of medications that are dispensed, and also the duration of the supply that is dispensed. And again, the key to note here is that these PBM practices will result in reduced patient access to the pharmacy of their choice. Next slide. Another key point to note here is that PBMs are making money from almost every player in the prescription supply chain, including the patient, but they never touch the medication. Next slide. So in response, NCPA has been supporting various legislative initiatives in both the House and the Senate. Next slide, please. And these are common sense legislative reforms that would stop PBM games. And we're happy to give you more specifics and further information if you're interested. But I'll talk about the bills mostly from the perspective of patients and how they're benefiting. So first, some bills in the Senate. The Drug Price Transparency and Medicaid Act, or S1038. This applies to Medicaid managed care. And it would prohibit spread pricing. And this is a practice where PBMs, in this case, charge Medicaid an amount that's greater than they reimburse the pharmacy for the same drug. And then they are pocketing the difference as a source of revenue. The bill would also limit payments to PBMs to solely administrative fees, so to keep their reimbursement, their compensation in check. Another bill, the Protect Patient Access to Pharmacies Act, or S2052. This mandates that plans in PBMs and Medicare Part D and Medicare Advantage must cover pharmacies' costs to acquire and to dispense so that they these pharmacies can participate as a willing provider in the PBM's pharmacy networks, thus enhancing patient choice of pharmacy. Also, the Pharmacy Benefit Manager Transparency Act, or S-127, this prohibits spread pricing, as I just discussed, but also this concept of clawbacks. So when PBMs will reimburse pharmacy a certain amount and then claw back a portion of that amount at a later time, making it creating a great degree of economic uncertainty for pharmacies, which then of course trickle down to access for patients. And then in the House, the Protecting Patients Against PBM Abuses Act, this bill would prohibit PBMs from reimbursing non-affiliated pharmacies at a rate that is less than they reimburse their own pharmacies. And this would get to try to control the PBM steering patients to their pharmacies of their choice. The bill would also de-link PBM compensation from the costs of medications, so bringing down how PBMs are being compensated in a more transparent way, and also would prohibit that spread pricing mechanism that I discussed earlier, this time in Medicare Part D. Key to note here is that some or all of these bills may be wrapped up into a Senate Finance Committee package that we're expecting later this year. Next slide, please. And another goal that NCPA has is to change the pharmacy access standards in Medicare Part D. We've found that Hispanics are particularly disadvantaged in Medicare Part D, and I'll discuss that shortly. So as part of this project, we partnered with the University of Southern California to develop a web tool that shows pharmacy shortage areas at the neighborhood level, also generates information on pharmacy closures and the populations affected. We have state and county level information on this and on specific pharmacy shortage areas. The key to note here is that 25% of the US population resides in a pharmacy shortage area. That means that 1 in 4 of Americans do not have adequate access to a pharmacy. For Hispanics, 15% of the total US Hispanic population resides in a pharmacy shortage area. But if you look at neighborhoods, 31% of Hispanic neighborhoods meet criteria to be in a pharmacy shortage area using our research. So that's almost 1 in 3 Hispanic neighborhoods. So thank you very much for bringing me to this presentation, and appreciate your time. I guess back to the moderator now. Thanks.
Thank you, Mr. Postal. On to our next topic. Osteoporosis is a silent disease that often remains undetected until complicated by fracture. While the vast majority, 80% of people affected by osteoporosis are women, 1 in 8 men also suffers from the disease. This rate is expected to increase as men live longer. Similarly, while osteoporosis is more prevalent in Caucasian and Asian populations, African Americans and Latinos are also at significant risk of developing the disease. To understand its impact on Latinos, NHCOA conducted a national survey to better understand Latinos' knowledge, attitudes, and beliefs about osteoporosis. Let's hear more from our next speaker, Ms. Cristina Pacheco. Ms. Pacheco is NHCOA's Director of Resource Development and Policy. Today, Ms. Pacheco will provide an overview of osteoporosis and Hispanics, presenting results from a national survey. Welcome, Ms. Pacheco.
Hello, my name is Cristina Pacheco, and I am the Director for Policy and Development with the National Hispanic Council on Aging. It is my pleasure to present the results from our osteoporosis survey focused on Latinos' knowledge, attitudes, and beliefs about osteoporosis. In partnership with Elevance Health, the National Hispanic Council on Aging conducted a national survey to better understand Latinos' knowledge, attitudes, and beliefs about osteoporosis. We surveyed 530 Latinos and found 19.4% reported being told by a doctor that they had had a diagnosis of osteoporosis. Osteoporosis is a condition in which the bones become less dense and are more likely to fracture. If not prevented or left untreated, bone loss can progress painlessly until a bone breaks, and that typically occurs in the hip, spine, or wrist. While more than 50 million people in the United States have osteoporosis, many still do not know much about it, and there's a lot of myths out there. Osteoporosis is a major cause of disability in older adults and can take a severe toll on one's quality of life. It is a common misconception that osteoporosis only affects white women. However, a 2021 Morbidity and Mortality Weekly report showed that the percentage of Hispanic adults with osteoporosis was higher when compared to non-Hispanic white adults and non-Hispanic Black adults. In a subgroup analysis, the age-adjusted prevalence of osteoporosis for Puerto Rican men was higher at 8.6% when compared to non-Hispanic whites and Mexican American men. While it's not entirely clear why Latinos have a higher rate of osteoporosis, there are some potential risk factors to consider. For instance, Hispanics are more prone to lactose intolerance than other groups, and studies have shown that Hispanic women consume less calcium than the recommended dietary allowance. Hispanic women are also more likely than white women to develop diabetes, which may increase their risk for osteoporosis. In 2023, the National Hispanic Council on Aging engaged its cadre of promotoras de salud in New Mexico, Texas, Florida, and California to collect survey data about osteoporosis. 530 Latinos were surveyed, and the data was analyzed using SPSS software. This table shows you who participated in our survey. We had a relatively even sample when you look at the different age groups. So roughly half of our survey respondents were between the ages of 18 to 60, and the other half were age 61 and older. Across both age groups, the vast majority of our survey respondents were female, and we did see a higher proportion of individuals in our older adult group who were single, divorced, or widowed. When we looked at education level, our older adult group was more likely to have a high school education or less, and less likely to have been a college graduate or had a graduate education. Our older adults were also more likely to live alone, less likely to have children under the age of 18 in their home, and more likely to rely on a caregiver. When we looked at our survey respondents' ethnicity by Latin American region, the vast majority of our respondents reported being of Mexican descent. Just less than a third reported being of Caribbean descent. Roughly 7% reported being of South American descent, and just shy of 2% reported being of Central American descent. We asked a series of 19 true or false questions about osteoporosis to understand knowledge. From those questions, we developed a knowledge scale where low knowledge was represented by getting 1 to 7 questions correct. Medium knowledge is represented by 8 to 13 questions correct. And high knowledge is represented by 14 to 19 questions correct. Again, we looked at these scores by age range and found that overarchingly, regardless of age group, over 60% of our sample did fall into that high knowledge group. However, we did see a statistically significant difference by age when we lumped low and medium knowledge versus high knowledge, and found that our younger group, that 18 to 60-year-old, did have higher knowledge than our older adult group. When we look at our overall sample, Just shy of 90% of all survey respondents had heard of osteoporosis, but the survey really shone a light on some significant opportunities for education. So roughly a third of our respondents were able to correctly identify that a person with osteoporosis will likely not have any symptoms such as pain before fracturing. This leaves a lot of room for education. Less than half correctly identified that white women with osteoporosis have the highest risk for falls. About 20% could not identify that sardines and broccoli are a good source of calcium for people who cannot eat or drink dairy products, which is important for a population with high lactose intolerance. 63% falsely believe that calcium supplements alone could prevent bone loss. Only 10% of respondents believe that vitamin D supplements are unsuitable for maintaining bone health. 18% did not identify high salt intake as a risk factor for osteoporosis, but it is. 27% of respondents did not know that there are multiple screening tests used to diagnose osteoporosis. And several of our respondents did not make a connection between osteoporosis and body weight, smoking and heavy drinking, and physical activity. When we looked at our survey respondents' beliefs, we found that 35% felt that they had weak bones, 39% felt that they had a high chance of developing osteoporosis, and 42% felt that their family history put them at higher risk for osteoporosis. When we looked at behaviors to understand areas in which we could intervene, we found that roughly 73% of all survey takers reported having access to a place for exercise. However, only 45% actually reported exercising regularly. 81% reported eating calcium-rich foods, but only 41% reported eating a balanced diet. Roughly a third shared that they had had a significant fracture or broken bone, which puts them at risk for developing osteoporosis later. 31% had reported that they had a current or a history of smoking. 20% reported consuming 8 or more alcoholic drinks per average each week. And then 46% take calcium supplements and 52% take vitamin D supplements. And then again, roughly a third had a doctor recommend screening for osteoporosis, and almost 35% have had a DEXA scan. As our population continues to age, these inequities in osteoporosis will increase dramatically. The National Hispanic Council on Aging calls on government to take decisive action in response to osteoporosis, which impacts individuals, our families, and our communities. With this information, we are developing a toolkit aimed at increasing knowledge and screening based on the gaps that were identified by our survey. Additionally, we urge Congress and federal agencies to prioritize and improve osteoporosis education, screening, fracture prevention, and treatment to address the inequities that exist with this disease. Partnering with community-based organizations that reach priority populations can ensure culturally responsive education and patient empowerment to raise this issue in clinics. Thank you so much for your time and for allowing us to share our results with you.
Thank you, Ms. Pacheco. Long-term services and supports, LTSS, including care received at home and in residential settings such as nursing homes, are highly racially segregated. Black, Indigenous, and persons of color have less access to quality care and report poorer quality of life compared to their white counterparts. Systemic racism lies at the root of these disparities, manifesting via racially segregated care, low Medicaid reimbursement, and lack of livable wages for staff, along with other policies and processes that exacerbate disparities. But let's hear more from our next speaker, Ms. Galila Selassie, a senior attorney in Washington, D.C., the Washington D.C. Office of Justice and Aging, a nonprofit legal organization that uses the power of law to fight senior poverty. Ms. Galila works to help state advocates improve access to long-term services and supports and home and community-based services, with a focus on improving equitable access for historically marginalized communities. Today, Ms. Selassie will provide an overview of health equity in nursing homes and housing. Welcome, Ms. Selassie.
Thank you so much, Oscar, and ask for everyone's patience as I'm dealing with a bit of a cough today. But if we can go ahead and move on to the slides. As Oscar mentioned, we'll be looking into inequities in long-term care with a particular focus on nursing homes. Next slide. And so when we're looking at some of the challenges in identifying and resolving inequities in long-term care, the bulk of this conversation is going to be centered around Medicaid. And the reason for that is that Medicaid is often the only payer for most people for long-term care. It's often a surprise for most people, but Medicare, actually, the program for the health insurance program for seniors, actually only offers very limited long-term care coverage, only about 100 days of nursing home care per benefit period, and then very limited home health benefits as well. Whereas Medicaid covers more than 6 in 10 of every nursing home resident in the country. So that's what we're primarily looking at. And so some of the challenges in trying to create a more equitable long-term care space is that disparities can occur as a proxy for race. So sometimes some of the studies have looked at like income or insurance status, geographic location, things like that, that makes it harder to determine whether these disparities are existing because of race or because of these other, socioeconomic factors. Although we have noted that a fair amount of studies that I'll point out have actually isolated those factors and have determined that even after accounting for those, yes, there are still racial disparities. And then the other big challenge is when we think about what kind of policy solutions we should need to recommend, how do you make recommendations that are targeted to address racial inequities without necessarily being race-based? Because obviously we can't have a policy that is purely benefiting one race for the other, right? But it also can't be colorblind or completely race neutral. And so as we get through these slides, you'll find that some of our policies may not be race-specific, but they have an impact on on communities of color who are facing the worst disparities in this area. So they have the most opportunities to gain from these policy recommendations. Next slide. And so looking at some of the data on nursing homes, sort of the three, there's lots of disparities, but sort of the big three that I'll touch on today are disparities in admissions. Usually, most of the time, people will get admitted into a nursing home following a hospital discharge if they had a stroke or a fall or some sort of acute ailment that requires long-term care recovery. And so what we found is that nursing facilities mimic the housing segregation that we see in many parts of the country, in that just like we see many segregated neighborhoods, we see many segregated nursing facilities as well. And so 80% of Black Medicare patients were admitted to just 28% of facilities, while 80% of Latino patients were admitted to just 20% of facilities. So as you can see, these are very, very concentrated amounts of folks who are entering these facilities, much like we're seeing in the general population, unfortunately. Rehospitalization rates is also a good indicator for the quality of a nursing home, because that typically means is that they're not receiving adequate care in the facilities. And one thing we've noticed is that rehospitalization rates for Black and Latino facilities across, Black and Latino residents across facilities tend to be higher, but less within the same facility. So that suggests that the type of facility has a much greater impact on these racial disparities than the specific makeup of one facility. But again, seeing how segregated these facilities are says a lot about what types of facilities Black and Latino residents are being sent to. And the last one is on nursing home staffing. And I have this slide on that. If we can go to the next slide. And staffing disparities are one of the big issues here. And there's actually a lot of policy action happening right now on this. Facilities with higher percentage of residents of color have fewer registered nurses, nurse aides like CNAs, and fewer skilled licensed practical nurses or LPNs. And this is particularly important because not only is this harmful for the staff, or excuse me, for the residents, but keep in mind that a lot of staff in facilities are women, are immigrant women, Hispanic women, Black women. A lot of populations that we're concerned about are also the ones who are working under really challenging, difficult positions where they're required to take care of a lot of residents, manage a lot of beds without nearly enough support. So there's sort of a two-way street here of inequities. And one study found that majority white facilities had registered nurse staffing levels 34% and 60% higher respectively than Black and Latino facilities. So if you can imagine that majority white facilities had 60% higher RNs than a majority Latino facility, which is insane because again, that says a lot about hospitalization rates, infection rates, quality of care, all of those factors. And in this study in particular, they've actually isolated for insurance and location, medical condition, things like that, and it still cannot account for the disparities. So this is particularly an acute area where there is some really horrifying racial disparities. Next slide. There are additional inequities in other aspects of long-term care, like Medicaid home and community-based services, which is basically a way of receiving nursing home level of care in the home and community. There seems to be suggestions that the data suggests that there's fewer access to these services for communities of color, but it's really hard to tell because the data is very limited. These are waiver services, so states are not required to provide these services. And when they do, they can provide it very piecemeal. So only one segment of the population gets it through this waiver, another segment gets it through that waiver, or it only applies to a specific region, and the like. So because of that, it's really hard for there to be a good data analytical comparison on these areas. But the data that we do have suggests that the access to care is really insufficient. So one example is that by age 80, 75% of people with dementia reside in nursing homes, compared to just 4% of the general population of that age. Hispanic, and the reason why this creates a racial disparity is because Hispanic and Black older adults are 1.5 to 2 times more likely to develop Alzheimer's and dementias. So you can see that cognitive impairments would be an opportunity where people could receive care at the home if they had the supports that they needed. But unfortunately for the disproportionate number of Black and Hispanic older adults who are facing Alzheimer's and dementia, they're much more likely to reside in a facility, is what we're determining from this data. And then some of the reasons for this inaccessibility, in addition to the confusion over these HCBS waivers and slots and wait lists and things like that, include limited access to affordable and accessible housing. Some HCBS services do offer housing accommodations, housing modifications. So for example, installing ramps or grab bars or things like that to make the home safe. But again, it's just so specific, not only to the state, but to that specific waiver. And then there's financial difficulties. A lot of more privileged older adults tend to reside in really upscale assisted living facilities, particularly for folks with dementia or Alzheimer's. That can be a great option for folks, but they're very expensive. And even in few instances where Medicaid will cover some of those assisted living services, Medicaid will not cover room and board. So people usually have to pay out of pocket thousands of dollars for room and board at some of these assisted living facilities. And then there's no standardization there. There's no standard eviction protections or rules around assisted living because it is so state-based. Next slide. And so some policy solutions that we have, going back to the staffing, nursing home staffing levels, the Biden administration recently proposed a rule early in September that requires facilities to ensure that there are that staffing ratios include 3 hours per resident per day of RN and CNA care. So 3 hours of nurse care per resident per day, which is significantly less than decades-long precedents. A study from the early 2000s suggested that there should be at least 4.1 hours per resident per day of care, and that's a combination of nurse aides, LPNs, and RNs. And the reason for that 4.1 hours is just the bare minimum to prevent unnecessary death and bed sores and injury and things like that. And so the fact that it's 3.0 now is something that advocates are very concerned about, has a huge impact on Hispanic older adults, on other communities of color, and on the nursing staff, on nursing home staff, who are, again, predominantly women of color, who are really the backbone of this group. And they're put in a really hard position where they're having to carry on an extra burden instead of having facilities hire more staff. Another big one is to increase staff training requirements. The federal minimum is 75 hours for nurse aides. Institute of Medicine recommends 120 hours, and making sure that those 120 hours are all encompassing, including things like dementia care, including things like special feeding assistance, cultural competency, things like that. And then making Medicaid home and community-based services a mandatory benefit. That way you don't have this hodgepodge of systems where it varies greatly depending on where you live and what kind of service you need. If you made that a mandatory benefit, it eliminates what we call the institutional bias, which means if someone needs long-term care, they're pretty much forced to go into a nursing home because that's the only way they can get Medicaid coverage for long-term care. And so instead, mandating HCBS would provide a meaningful option for folks who want to avoid the institutions. Next slide. And then these are just some of our justice and aging resources that folks are welcome to take a look at. And on our last slide is our email. And if you want to join our listserv, or if you have any questions, you're welcome to email us. Thank you so much. It was a pleasure being here.
Yep, okay. Thank you, Ms. Selassie. The Latin American population is increasingly affected by obesity and its negative impacts on health. As obesity rates continue to climb, the Latino community is still recovering from the impacts of COVID-19. The coronavirus pandemic increased a disproportionate number of Latinos while simultaneously dealing with an obesity epidemic. However, obesity is a treatable disease through behavioral therapy, bariatric surgery, and pharmacotherapy. Due to outdated regulations, Medicare does not provide access to the full continuum of obesity care available to patients. Let's hear more about this topic with our next speaker, Ms. Amy Hinojosa. Ms. Hinojosa is the president and CEO of MANA, a national Latino organization, the largest Latina membership organization in the United States. She is responsible for the operations and oversees the educational programming of the national organization, as well as national advocacy efforts. Today, Ms. Hinojosa will provide an update about obesity current policy landscape. Welcome, Ms. Hinojosa.
Thank you so much, Oscar. Obesity is such a difficult and important conversation to have. Today, 40% of Latinos in the United States suffer from the disease of obesity. 1 in 4 Hispanic children and half of all Hispanic adults suffer from obesity. Almost 4 in every 5 Hispanic women are overweight or live with obesity. We're all very familiar with the impacts of obesity and your overall health. Everything from high blood pressure, diabetes, cancer, other cardiovascular disease. And we all know family and friends with severe cases who have severe limitations on their lives as a result, whether that's physical limitations, chronic pain, disease, decreased mobility, mental health struggles, all among the impacts. And as we enter this fall season with flu and RSV, and yes, COVID concerns, it's important to remember that COVID ravaged our communities, our Latino communities in particular, because of those underlying conditions. And, you know, I think that all of us know folks who suffer with all these things. If you've ever gone to the doctor, often the first thing they tell you is you should probably lose weight. And it feels like across the board. And how many of us have heard from friends and family members, I'm not going to go to the doctor to get any of that treated because all they're going to tell me is to lose weight. If it were that easy, I would just do it. And I think that the good news is that science is finally catching up to what we already knew. Yes, a healthy diet and exercise and taking care of your heart health, those are all important pieces that go along with making sure that you're healthy. But the disease of obesity finally has the ability to be treated with medications. We now have anti-obesity medications that directly treat that disease in combination with those evidence-based healthy eating and exercise behaviors. And they're FDA approved. Our problem is that they are not readily available yet and remain inaccessible to communities of color and poor underserved communities. And, you know, this is why we're looking to Congress. And, you know, sometimes in this environment, it's difficult to look to Congress for anything. But there's a piece of legislation that's being considered. It's called the Treat and Reduce Obesity Act, TROA for short. And the bill would significantly expand Medicaid coverage under Medicare for obesity screenings, treatment, FDA-approved therapies, such as those anti-obesity medications, and eliminate barriers for millions of Americans living with this chronic disease. And the introduction comes because momentum is growing for updating obesity policy, and health advocates like MANA, like the Health Equity Coalition for Chronic Diseases, which we're a member of, along with the National Hispanic Council on Aging, and so many other diverse national organizations have been, you know, raising the alarm bells over, you know, we treat obesity not as disease, and we treat it as a moral failing. And the truth is that, like I said, if it were just that simple, folks would just simply do what they need to do to lose weight. It's not that simple. Our body chemistry requires these medications to be able to make those moves forward. And, you know, I think we get it confused oftentimes with weight loss drugs, right? Over the years, we've seen lots of weight loss drugs. We see all these commercials, but we're talking about FDA approved treatments exactly for this disease. And, you know, if you went to a doctor with a mental health issue, or if you went to a doctor with a heart condition, taking a medication is a logical next step. You know, right now in the continuum of care for obesity, you go and they tell you either lose weight, or the next step is a bariatric surgery or some kind of another type of surgery. And those seem like very extreme things. That you mean to tell me that if I can't lose weight, then I need surgery, and there's nothing in between to treat it. And now we have these anti-obesity medications. The problem is they're just not accessible. And this is why the TROA legislation is very important. And we know that the Energy and Commerce Committee just had a hearing last week where TROA was mentioned, in that it was a hearing on access for seniors. And we feel that this is really important, but we need to start making the distinction, and we need to make sure that we're having conversations that relay the difference between weight loss drugs and the treatment of the disease of obesity. And this is really where the conversation is going to hinge, because we want to make sure that folks who need it are getting access to these medications. You know, we saw COVID devastated our communities because all the underlying conditions of diabetes, heart health disease, those are all the things that made us most susceptible to COVID and the impacts of it. And we, you know, our community had a lot of death as a result of it. And so in pushing forward conversations like TROA, what we're trying to do is stem that tide before the next pandemic hits, or if, you know, the mutations on the current COVID disease are able to hit our communities in awful ways. So what we're looking at, it looks like the NHCOA is being taken very seriously. We need to make sure that we're continuing to advocate to make sure that we're talking about the treatment of the disease of obesity and not just this vanity weight loss that, and I think that you see if you, you can see all the articles and, all the publications that you see at CVS or the grocery store talking about how someone lost a significant amount of weight. But what they're not talking about is the need for that and the need for it to treat their health conditions, not just simply as a vanity drug. And so once we get to the point where we can stop seeing weight loss as an issue of vanity and a real health need, then we're going to be able to move forward on these conversations. But what we really need is for Congress to pass NHCOA, and we're happy to report that there is bipartisan support. We just need to make sure that we're getting it to the point where we can push it over the line and folks understand how important this is. If this could immediately help 50% of the Hispanic population, 4 out of 5 Latinas, for us, this is why the issue is super important, and we want to make sure that we're continuing to put that pressure on Congress to act so that folks can have access to these anti-obesity medications and access to the care that they need before it gets to the point of being something so severe as a surgery or other ways that just seem like very severe answers to something that we have medication to treat in this day and age. And so, we're very grateful to Dr. Cruz and to the team at NHCOA for continuing to uplift this conversation and for continuing to advocate for, one, these types of medications and access for our community, but then also for the legislation that's really going to push that forward in a meaningful way. So we appreciate the time and the attention to this conversation. Thank you.
Thank you, Ms. Hinojosa. Over the last 3 years, racial and ethnic minorities in the US have experienced higher COVID-19 infection and mortality rates than their white counterparts. COVID-19 continues to disproportionately impact Latinos, leading Latinos to suffer the highest rates of COVID-19 hospitalizations and death. Even though treatments for COVID-19 are available, we still experience racial and ethnic disparities in outpatient treatment of COVID-19. There are multiple factors that contribute to the lack of awareness and access of COVID-19 treatments. But let's hear more from our final panelist, Dr. Hector Cabrera. Dr. Cabrera serves as Associate Chief Medical Officer for Premier Health, now approaching 100 clinics in 13 states. Premier Health is one of the leading urgent care operators in the US. Dr. Cabrera has served as Medical Director at LCMC Health Urgent Care in New Orleans since 2019. Today, Dr. Cabrera will highlight COVID-19 treatment and Hispanics. Welcome, Dr. Cabrera.
Hi, Oscar. Thank you so much for inviting me to speak. So happy to be here and to try to share what knowledge I've gathered during this pandemic in the urgent care primarily, which is my primary job. Shout out to urgent cares, over 11,000 strong throughout the country, and the role that they played in this pandemic in the front line for sure. But also informed by experience that I have serving as medical director of several long-term care communities in the area where I live. So tremendous impact that has changed my life professionally and personally as well. As we heard earlier in our introductions, Latinos have been disproportionately affected by this pandemic. Disproportionate in the number of cases, in the number of hospitalizations, and in the number of deaths. Current count is 1.14 million deaths of US citizens in this country, and greater than 30% of those identified as Hispanic. And that's probably an undercount, as many deaths from COVID did not report ethnicity or racial data. So we think it's probably even more. Now, the good news is that the pandemic has changed. It hasn't gone away, but it's changed. What we're seeing are bumps instead of the peaks when there's a surge in our communities. And most often, it's less severe disease. There's less hospitalizations and less deaths. Less, not none. They're still occurring. In fact, I was a little bit shocked as I was preparing for this talk. I gave a similar presentation at the NHMA conference in April. And in that time, that number has increased, number of deaths in this country has increased by 40,000. So it's not over, it's changed. Now, what has helped change what we see clinically with regards to COVID? Vaccines, for sure. A greater rate of immunity from vaccines or natural immunity from having had the illness has mitigated those peaks, and we see less severe disease. And then access to therapeutics. Unfortunately, with the current circulating variants, the monoclonal antibodies that had helped us so much during the peak of Omicron are no longer effective. What treatments do we have? We have COVID antivirals. These are medications that'll help your body fight the illness. Now, one thing that has become clear with those medicines is that they're being underutilized among the communities that are at highest risk, especially the Latino community. The CDC published a report in in October of 2022 in the MMWR that revealed that Latinos were 30% less likely to have COVID antivirals prescribed to them if they were diagnosed with COVID. Why, we ask, when these tools that are effective, that are safe, that'll help reduce the risk of hospitalization and death aren't being utilized in our communities? I've read something recently that provides some insight, and it kind of reflects what I've gathered from seeing patients in the urgent care when I asked them, what brought them in. More diagnoses are occurring at home with home COVID tests than in clinics or in primary care, but certain groups are coming seeking treatment. And what I read provided some insight into that. People getting treatment know about these treatment modalities, know about these COVID antivirals. They also know that they are at risk. They know the risk factors, who these medicines are most likely to benefit, motivating them to seek treatment. And for most of the people, another leading incentivizer to seek treatment is that they had been recommended by someone that they trust, be it a healthcare provider or a family member. So with the time remaining, I kind of want to utilize that time to educate all of you that are listening about these COVID antivirals. So you know about them, you know who's at risk in the community, and you might be that trusted contact that'll motivate someone in our community to seek treatment. So what are they? COVID antivirals that are effective now, they're known as protease inhibitors. Essentially what they do is they reduce the ability of the virus to replicate. They all work that way. We have 3 of them. One of them, called remdesivir or Veklury, needs to be administered through an IV infusion for 3 consecutive days. It's highly effective. There's a relative risk reduction of 87% in the studies that were used to get it authorized. 87%, it reduces the risk of developing severe disease, hospitalization and death by 87%. Problem with this medicine is that it needs to be administered through IV infusion, and so most of my patients that get this are sicker patients that end up in the hospital. The other 2 medicines that we have are oral medications. They're both treated for 5 days, and they work best if they're started earlier, within 5 days of symptom onset. One of them, called Paxlovid, is highly efficacious, as beneficial, as effective as the remdesivir 88% in the studies were shown to reduce the risk of developing severe disease. It has been studied in pregnancy and it's being utilized for pregnant patients. Problems with this medication are drug-drug interactions. And so knowing your medications, if they seek treatment, is very useful in helping your clinician be able to determine the best treatment for you. There's renal adjustment that needs to be done with this medication based on the kidney function of the patient, and they're approved for 12 years and above. The third medication that's available is also an oral treatment. It's called molnupiravir or Lagevrio. It's not quite as effective as Paxlovid. About a 30% risk reduction was shown, but 30% risk reduction for someone who's at risk is still beneficial. Not everyone can take Paxlovid for the reasons that I mentioned, and so molnupiravir exists as a good alternative. It's oral, there's no significant drug-drug interactions, there's no renal adjustment that needs to be made. However, it cannot be used in pregnancy, and it's only approved for 18 and above, okay? Supplies are still plentiful of these COVID antivirals, so they should be free for most of your patients, but it's kind of uneven throughout the country where that availability still exists. So it's important to kind of know your local resources. So that's about them. You know about the medicines. Now, who are they for? Who are they most likely to benefit? You know, I teach my clinicians in the urgent care about COVID-19 risk continuum, to think of it as a spectrum of benefit. Excuse me. And to consider 4 factors when prescribing this medicine. 4 risk factors. First is age. And of course, the older you are, the higher your risk of developing severe disease. The younger you are, the lower the risk of developing that severe disease. COVID antivirals are indicated for patients that are 50 and above. However, we know the greatest benefit is for our most elderly family members, 75 and above. 75% of the deaths that are still occurring are happening in patients that are 75 years old or older. The second factor to consider are medical conditions. So, and it does matter how many medical conditions. These are the risk factors that someone can have that also puts them at risk for more severe disease. They include medical diseases like hypertension, diabetes, chronic lung disease like COPD and asthma, chronic kidney disease, heart disease, obesity, and smoking. So these are factors that will increase the risk for a patient. The more you have of these, the greater the risk. The less you have them, or if you have none, the lower the risk. Next factor is vaccination status. So greatest percentage of patients that are still dying from COVID are elderly. Second greatest subgroup of patients that are still dying from COVID are the unvaccinated. So vaccination status is a risk factor. Spectrum ranges from being completely unvaccinated, no boosters, never had the illness, no natural immunity. Of course, that's the greatest risk. Absolute indication for COVID antivirals if diagnosed. And then the least risk is someone who's fully vaccinated and boosted within a certain time frame, or may have already had the illness once or twice. Those people exist. They have the highest vaccination status. The fourth group I want to talk about are patients that are immunosuppressed. There are certain categories of immunosuppression that also put patients at higher risk. Our greatest category are people that are receiving active treatment for certain cancers, people who've had stem cell transplants, are patients that received organ transplantation and have to receive immunosuppressive therapy on a chronic basis. And then there's a spectrum of other illnesses, maybe patients that are on immune modulators, are patients that have lupus or rheumatoid arthritis or severe psoriasis, are on medications that weaken the immune system and that are at risk as well. So think about the risks to you, educate your community about if they're at high risk. So knowing about the medicines, knowing about your personal risk of developing severe disease. And then the last piece that we talked about that may increase utilization in our community is to have them recommended by someone they trust. We've learned that lesson with the rollout of the COVID vaccine, the importance of having those trusted community leaders involved in the education and the promotion of these medications. Okay, and so all of you can play a role for your family member, for your community in educating people about it. If you know about them, if you know that you're at risk, it'll increase the chances that you'll seek treatment for them. Okay, thank you so much for allowing me to be here.
Thank you, Dr. Cabrera. And before we conclude, I would like to introduce Robert Bob Blancato, NHCOA's board member who is recognized as a national advocate with policy expertise on behalf of older adults. Mr. Blancato.
Thank you very much, Oscar, for the introduction. And if somebody can move the slides, I will be happy to. Let's go right to the next slide. So, as a board member of NHCOA, I commend the INERA and all others responsible for this important webinar. Clearly, the topics discussed today were important and the presentations were compelling. And part of the story they told was, in our appropriate focus on health equity in America, we must have all the data necessary to determine who is in most need of attention. We know when we talk about disparities, it is a fact that the group that has suffered them the longest are older adults, especially minority older adults. Next slide. What we learned today from Dr. Irizarry and from the report are important in shaping our future advocacy work. In the Alzheimer's space, Latino individuals have high rates of Alzheimer and other dementias, but Latino participants comprise a fraction of enrolled patients in clinical trials. So increasing diversity in clinical trials is an advocacy priority. Osteoporosis, what we learned from Christina and the report. The issue is the need for greater education and awareness, especially in Hispanic population. And the survey found that under 20% of Latinos reported being told by a doctor that they have osteoporosis. We know the rates are likely higher and will grow as the older population grows. Next slide. I'm a very proud member to be the national coordinator of the Elder Justice Coalition, and NHCOA has been a longtime member. And what Galia Selassie said from the Great Justice and Aging Organization, what she reported and what was contained in the report is quite disturbing. Nursing homes with higher percentage of residents of color have fewer RNs, nurse aides, and skilled licensed practical nurses. Advocacy priority is to provide public comments to the just released proposed rules on staffing in nursing homes issued by the Biden administration. And we must, as was called for, advocate for home and community-based services to be offered as a mandatory benefit as called for in the report. Next slide. Thanks, Steve, for his presentation today. Steve does this a lot, and we appreciate his work. Our focus needs to be on passage of pending legislation to mandate greater transparency in the work of PBMs. To reiterate, we need to strongly advocate for the passage of the Modernizing and Ensuring PBM Accountability Act reported out by the Senate Finance Committee, and we need the House to join in passage this year of this important bill. Next slide. And Dr. Cabrera's excellent presentation just before me reminds me of the work we've been doing in the vaccine space with UNERA. and other groups to ensure that older adults have access to the most current vaccines. In this nation, we have a remarkable record of having vaccines produced to address healthcare needs. But we are very glad that the advisory committee that guides the Centers for Disease Control voted 13-1 to allow the newest COVID-19 vaccine to be made available for all persons 6 months or older without shared decision-making, a barrier that had kept a lot of older adults from getting the vaccines that they needed. And as executive director of the National Association of Nutrition and Aging Service Programs, we had many communications with ACIP and CDC, all signed by NHCOA, seeking an end to shared decision-making wherever it was applied. The next target is the new RSV vaccine to be made fully available without shared decision-making, because RSV is a new and serious threat to older adult health, and we must stay on top of it. And then finally, this webinar and this whole activity is about advocacy to get us to where we need to be. What we've learned today and what's in the report provides the information we need to do good advocacy. NHCOA is your important national voice, as Jorge, the chairman, has said before. And what happens locally makes our work more impactful. So I urge you to remember two basics of advocacy for those who have joined this webinar. Number one, keep your data and your stories up to date. And number two, if you see something you don't like in policy, don't accept. Advocate to make it better. Thank you very much.
Thank you, Mr. Blancato. Again, thank you to our sponsors, speakers, and the attendees for joining us for today's virtual event. For more information about the release of this report, please visit NHCOA's website and social media channels, X, Facebook, and Instagram using @NHCOA, NHCOA. Let's continue advocating for programs and resources that better support older adults and their caregivers. Until the next one, thank you and gracias.